Hello. How you doing?
Good.
Great. Good. Thanks for having me along today.
It's amazing to giving up your time coming in and talking to us guys.
It's totally fine. So who's coming? Who is it for?
I run 2 groups at the moment on Facebook, basically for people that have been learning or have got a good understanding of hypopressives. They've come to me through kind of taster sessions with pelvic floor dysfunction and looking for a solution. So for most of them, they've had some really good outcomes. I've been running the group now since kind of November, and I started this last month, April and May, to do a bit complete beginners, so teaching it completely via Facebook Lives, so little 15-minute videos every day. But pretty much everybody that's going to be here today has some form of pelvic floor dysfunction. More specifically, it's to do with prolapse and what else we can be doing to help ourselves. Just getting a little bit better informed, a bit more knowledge about it. So thank you very much, everybody, for turning up. We have lovely Anna Crowle here this morning, and she's just going to do a very brief introduction about herself, very brief, and then we're going to go around and come to your questions. So, now, without further ado, I'm going to hand over to Anna.
Hi. Hi. Thanks so much for having me along this morning. So I'm Anna. I am a women's health physiotherapist, and my background was in myofascial release before I got into women's health physio. So that's my perspective on things. So myofascial release is the study of the connective tissue of the body, really. Recently, I've been doing some research around how I think prolapse is caused by tension within the pelvis rather than weakness. So my way of treating, the way that I help women when they come in and see me in leads, is to focus on finding tension, which I believe is what is causing the disruption in organ position rather than weakness.
Brilliant.
Is that all right?
Yeah, that's great. Right, so hands up. Who's got a question?
Sarah's waving.
So unmute yourself, Sarah. I've muted you, so just unmute yourself.
Okay, there we go.
So
I got a new phone as well, so everything's in the wrong place.
Okay. Far away.
Hi, Anna.
Hi, Sarah.
Yeah, I have watched your video, and it's actually really amazing. So very, very interesting, because I've been interested in this kind of thing for quite a while. I have recently had a hysterectomy though, and I know on your video you said you can't do what you say on there due to having had a hysterectomy, and it's only recent, so I wouldn't attempt it anyway. So my question is, I don't have prolapse at all. My hysterectomy was due to something else, but I have always suffered with the tight pelvic floor, so I don't do like the traditional Kegels, which is why I started the hypopressives. So I guess I'm just wondering, you know, is there anything you can suggest that would carry on helping with that?
So what I'd suggest in your position, if you've not got a prolapse and you've had a hysterectomy, is I'd get yourself into a good quality local Pilates or yoga group. So a functional exercise program where you're working with people that have got a lot of experience in working with women post-surgery or with pelvic floor dysfunction. So people really that are experts in the field, and having some regular good quality movement that you do every week. That's really what I would do to try to maintain it. But you're right, if you've got a hypertonic pelvic floor, to not be doing pelvic floor squeezing. So to keep everything working in a nice mobile and connected way, then alongside the hypopressives, a nice well supervised Pilates or yoga. Does that sound okay?
Yeah, I did used to do Pilates, but it was a big class and it actually exacerbated a lot of my problems, because a lot of the instruction was like all about the pelvic floor and everything, and I probably maybe overdid it.
So that's an issue within Pilates that's so across women's health, really, be it physios or massage therapists or movement teachers. There's 2 schools of thought, really. There's the Prolapse is caused by weakness, so get everything zipped up and in, and lots of repeated squeezing and prop it up. And really that is a whole school of thought. And then within that, you've got physios, massage therapists, Pilates teachers. And then there's the other school of thought where it's more about looking for release and alignment in the body. So whatever your profession, you kind of sit in one of these two camps. So from a Pilates angle, I've got a fantastic colleague called Claire Sparrow. It's Claire, Claire Sparrow. And she's got quite a bit of stuff on the internet. So she has designed a release-focused Pilates-based movement, and the people that she's connected to or could put you in touch with all over the country, or she's also got online resources. So some places are really blessed with Pilates teachers that are just really on board with a sort of release-focused arrangement and alignment balanced movement program, and that's fantastic. What I'd say if you're looking for good quality Pilates is you want to know what their qualifications are, and you want to be working in a class of about 5.
Right.
More than that, you're not getting looked at. If you're in a leisure centre in a class of 30 and somebody...
I was doing it at David Lloyd, and it was like a huge class, but it just seemed to cause me more issues.
So you need to go with the higher quality stuff. So you need to know their credentials in women's health and pelvic health, and it needs to be a really small class. And it's actually it's a really different thing than what you'd find in a big leisure centre.
Lovely, thank you.
I'm just back on mute. So I think you're right in the fact that there are two schools of thought, and that you know, I'm very much on the side of the movement and release with what we do with hypopressives as well. So I don't know how much you know about what we do, but again, that's
not huge amounts actually. I don't know how much amounts,
but definitely works along. That's why I've been so keen to kind of talk to you, because everything I say, you're saying it out loud, and you've got the research behind you to kind of back that up. Whereas I think that very much the school of tension and Kegels, etc., have poo-pooed hypopressives, pushed us to the one side, thought we were just not qualified to be doing what we're doing, and yet actually every day seeing amazing results with my clients through just doing something as simple as breathing properly and movement and alignment in postures. So
change is difficult. Changing the system, you know, the system has been saying for decades that prolapse and pelvic floor dysfunction comes from the organs falling out of the vagina because women are inherently weak. You know, it's steeped in historical patriarchal viewpoints on the female body, and really it's based on an anatomical model which has been disproven. So the old anatomical model, the way that the human body has been described and understood across medicine since the 1600s, is that we're built like a stack of bricks, that the legs rest on top of the feet, that the pelvis rests on top of the legs, the spine rests on top of the pelvis, and then the head is resting on the top, and that movement came through a system of levers. And that's the way that human movement has been understood since the 1600s.
It's madness.
It's wrong. It's wrong. That's not how the human body works. If that's how we worked, then jumping, everything would just crash and crumble into millions of pieces. Doing a handstand would be impossible. Babies wouldn't be able to crawl. You know, there's huge misnomers in this. So quite a long time ago, so back sort of 70s, 80s, a completely different model was proposed, which is that actually it's our connective tissue, which is this whole body, 3-dimensional web, this connective tissue, which is this sort of kind of soft, springy, elastic stuff, and everything else in the body is embedded within that. And actually, this new way of understanding the body has been really, you know, we've scienced it out to the max. You know, it's been proven that that's how nature works, be it plants, be it animals, be it viruses, down to a cellular level. We know that the body is not a system of stacked components, that the body is actually held in its own stretchy elastic web. We know that, but changing the medical system and changing the pervasive thoughts takes a lot of time. So really in gynecology and in women's health, this idea that a uterus, a bladder or a rectum just falls because it's not being held up from below effectively is actually a really outdated way of understanding the body. So a more modern way of understanding what's happening in the pelvis is saying, well, if we're all held in this stretchy dynamic web, what can knock that out? What can change that? What can cause problems? And actually that's tension somewhere in the system pulling. So say it's tension in your pelvic floor, that can pull the bladder. So yeah, it's pulling the bladder down and it feels low, but it's being pulled down by tension in the pelvic floor rather than it falling down because the pelvic floor's too weak.
Yeah.
Does that make sense?
Absolutely, 100% with everything that I tell my ladies. So, you know, it's so refreshing to actually have a women's health physio that doesn't just talk about Kegels.
The change is coming, but it just takes a long time. You know, I think if we look back over the last sort of 10, 15 years, there's been so much change around antenatal care and birth. You know, it really feels like feminism has just come up and through with birth activism, and actually we're going to reclaim this and demedicalize this. And it's just, you know, it's fantastic. It's really improved outcomes for women. And actually now that wave is happening, I think, in postnatal and longer term pelvic floor issues is we're just starting to you know, take hold of these issues and go, actually, let's modernize things, let's do things right.
Yeah, it absolutely needs to, doesn't it?
Absolutely.
Okay, question from Tabitha then. So unmute yourself. Tabitha's in America.
Hi, Tabitha.
Good morning. Yes, I was slow to raise my hand. It's 5 a.m. here, so I'm still waking up. But I really appreciate you doing this. And my main question, I guess, was about if you had any suggestions on what to ask providers in terms of any training they've had or what terms to use when if we want to try to interview them to see if they are on the same way of thinking as you in terms of treating prolapse. I mean, myofascial release is obviously one of them, but I've been to a provider for several months and had made good progress in terms of my breathing and my posture and different things, but there's still like a sticky spot, you know what I mean, that I can feel. And I'm seeing a new provider who I think will be more helpful, but also more expensive. So that's why I went the more traditional route in the US in terms of having it covered by insurance first, but I'm definitely looking to, make progress and not always have this little bit of achiness or stickiness in my left hip kind of thing that I feel like is definitely the cause of a lot of issues in my pelvic area.
Yeah. So as I say, there's these two schools of thought and this change is coming through, it's like a tidal wave. So what I'd suggest you do is when you're phoning up a provider to see if you want to book in with them, I would say to them, I believe that my prolapse is coming from tension in my pelvis. Can you help me with that? And they're either going to go, well, that's not the case because prolapse doesn't come from tension, in which case, thank you very much, or they're going to go, yeah, okay, I can help you with that. I've done this, that, and the other training. In the US, your top providers of training are Herman and Wallace. So if anyone's trained with Herman and Wallace or Ramona Horton, that'd be really good starts in the US. So yeah, what I'd suggest you say is, I believe that my prolapse or my pelvic floor dysfunction is coming from tension. I believe it's connected to my left hip per se. Go with how you feel about your condition. You are the one in charge of your condition, and say, I'm looking for someone that can help me to find and release the tension inside my left pelvis. So, and they're going to have many, many tools. A lot of people, their favorite tool is movement therapy. A lot of people, their favorite tool is external body work. Some people, their favorite tool is internal body work. And actually, I don't think it matters what the tool is. There are many roads to Rome, and all practitioners work in a different way. So all you really need to find out is, are they in this camp or this camp? So you're very welcome to send them my website or my resources. A lot of people find that useful because of this, because this way of understanding pelvic floor dysfunction is new. quite rightly, any practitioners want to see evidence for it. Quite rightly, they want to say, well, where's your evidence for that approach? And that's why I've done this research, is so that women can be empowered by waving that, going, here it is. So you can access, I've got one research paper that's accessible on the internet now, and another one that will be accessible very soon over the next couple of weeks, which they'll both be on my website. As a non-clinical professional, it's quite difficult to access the full paper. You can pay the publishers. For the record, I don't get that money, but the publishers, you can pay them. But any healthcare professionals should be able to access it for free. So if you just go with the bit that you can get on the internet, they should be able to access the full paper, and that essentially is the evidence for the tension-based approach. Okay, so say again.
Is it on PubMed?
The first one is on PubMed, and the second one should be on PubMed any day, week. Now it's taking forever.
Okay.
Yeah, thank you. I did send your link, and I think the interview you did with Dr. Bree to my previous provider, and she said that was, I think her words were, it was interesting and it was good if it helped me kind of process how things were going in my body. So hopefully I opened her up to that information. But
it's actually, this is actually part of the movement. You know, this is so important to create change for all women. If the women that are aware of the other way, the different way, go to their provider and say, I would like it like this, please. That provider then goes, oh, there's another way. Right, let me look that up. And, you know, step by step, moment by moment, the change comes. Yeah. So
yeah, my new provider is she does trainings for Herman Wallace. So I'm hoping that I'm definitely going in the right direction. Thank you so much.
Thank you, Tabitha. Okay, Michelle, you have a question.
Yeah, so totally resonate with everything that you're saying. I have tight fascia throughout the whole of my body. And I was aware that my breathing was out of sync, so the hypopressives have really helped with that. Done some massage. I'd stepped away from Pilates and yoga because I felt it was making it worse. So thank you for the tips on that. So I'll explore some different classes. So yeah, very much my body is completely twisted from my hip through to my shoulder because I think the fascia's been so tight for so long. And
sorry, guys.
Yeah, I've got episiotomy scars and C-section and all sorts. I'm just wondering if there's anything else you can suggest to add as an integrated program. So if you've got the hypopressives and looking at the massage, the internal massage, and the move, is there anything else that we can add when the body's twisted to the extent that
the body is very resilient and will keep on healing? So yeah, if you're doing the hypopressives, and like I've said, the good quality, well supervised, tiny little class of 5 with somebody qualified up to the hilt, as opposed to a leisure centre with 30 people in it. And are you having body work? Are you having massage or osteopathy or myofascial release?
I've had some myofascial relief. There's a lady that I have as massage. She's amazing, but she's so busy. It's really hard to get booked in. So I'm having it probably about once a month, and I'm conscious that's perhaps not enough. Again, I've been doing some bowing, but again, I have to only get an appointment about once every 4 to 6 weeks. I've tried McTimony chiropractor. If anything, I think that made me feel worse because I think it was trying to work on the joints and the fascia was too tight.
Osteopathy is a good option. So again, you need a women's health specialist. Again, you need somebody that's really qualified, that knows what they're doing with pelvises and with the female body. So for myofascial work, the Jing, you're in the UK, Michelle, yeah?
Yes, yeah, I'm in Worcestershire, so I'm pretty much in the middle of the country. Yeah.
So the Jing College, that's Jing, Jing College of Advanced Massage Therapy. They're based in Brighton, and they basically are the best qualified massage therapists and myofascial release therapists in the country.
Yeah. And
they have a practitioner list. So what I'd recommend you do is go to the Jing website, Jing, and ask for one of their practitioners. and and basically book yourself. They normally recommend 6 sessions for people with a series so that they are external body workers, but they are absolutely first class. So I'd get yourself a course of treatment with them. Also, osteopathy is a good option. So I would be looking for a women's health specialist osteopath.
We've trained. So
say again.
I said there's a few on our hypopressive course list that are
great
women's health osteopaths that it might be worth looking at.
Great.
I don't know any that are kind of in your area, Michelle, but they may very well be doing some online stuff.
And maybe the sad reality of things at the minute is, to get what you want, you might have to travel a bit. It's just not everywhere, which is why everyone can help by going to their local provider first and saying, I would like it like this, please. And then if they can't provide that, moving on and finding somebody that you travel to. But you've raised the awareness with that local practitioner. So maybe she's going to go then and do some courses. And then the next woman that comes along, she might go, actually, yeah, I can help you. So, it's all part of the tidal wave.
Thank you.
Who was next? I think you all came in on a little flurry there. So let's go to Lorna.
Hi, Anna.
Hi.
I've just got so many questions. I don't know where to start.
A bit short.
Well, I'll just kind of I'm doing a yoga teacher training, and I'd really like to make it focused on core and women's health. And who do you know who I should train with to kind of get that specialist?
On a yoga front, I'm less tapped into the yoga networks. I know Uma Dinsmore Tully has got a great reputation in women's health. I'm not sure what her training possibilities are. What else was I going to say there? So the big no-no in yoga, so the one that is not appropriate with pelvic floor dysfunction, is Ashtanga.
Okay.
It was designed by men for men. It is for the male body. So the female pelvic floor is not the right thing for Ashtanga. So pelvic floor dysfunction, steer clear of Ashtanga. Okay. But Yin and Hatha, and I think I'm not that hot on yoga, but I think some of the other forms are derived from Ashtanga, so I would steer clear of them, and I would focus more on the Yin and the Hatha styles.
Okay. Yeah.
Essentially, there are some yoga poses, including the planking and the boat pose. So planking and boat pose.
Yeah, I know boat pose. Yeah.
Boat pose, but also the planking in the sun salutations is a problem for pelvic floor dysfunction, which is essentially that's heavily used in Ashtanga. So no planking and no boat pose.
Does that mean no chaturanga as well?
I think the chaturanga is an aggravator. I don't think the chaturanga is suitable when there's pelvic floor dysfunction.
Okay.
So Lorna, you'd work well with hypopressives, incorporating it into your yoga practice as well.
Yeah, can you do that? Can you make that as part of a yoga?
Absolutely. I mean, we have many fitness trainers that we've trained that incorporate it with Pilates and yoga. So Mandy's waving because she's one of our trainers and she's done exactly that. She works very much in kind of the women's health side of it. Incorporated it really, really well. Again, it's just knowing that yoga and Pilates are the most well-known of those types of things.
Yeah.
But there's absolutely no
reason
why you can't do
range. I've just thought there's somebody in Leeds near me as well who does training for yoga teachers. She's really on board with the tension concept, which is her thing is called all-woman yoga.
Okay.
She might be able to put you in touch with somebody local to you. So that's all-woman yoga. As you say, Nikki, there's Pilates and yoga are the more common ones, but for sure it doesn't really matter. Functional movement is functional movement.
I think it's like you said previously, it's that movement is that hypopressives just isn't known about.
Yeah.
So unless everybody here is going and saying, I want you to train in hypopressives so that I can do hypopressives with you, then it's exactly the same with you. People don't know about it. And they
Yeah.
just look at it. They just look at it as something that is the same as yoga and Pilates, and it really isn't. It works very differently. So, you know, it's a good add-on. There's no reason why someone who's a yoga
Exactly.
Pilates trainer can't have that as well. Especially, it's very important if they have women that they're training, and the majority of people's clients will be women. So.
Yeah.
And if you're a Pilates teacher setting up in a small town, and you get 10 women come to you over 6 months going, I really want you to be doing it like this. Do you do it like this? No. Okay, I'm going to go an hour out of town and take my business elsewhere then. She's going to do that training.
Exactly.
Yeah.
And then a year later, the next woman comes through saying, I really hope that you do this, that, and you're just like, yes, I do. And then, you know.
Yeah.
Yeah. And Lorna, for you to be specialising and having that knowledge of hypopressives that you've already, you know, you've had the benefits yourself, and being able to offer it in your area, it opens you up as probably the only person in your area.
Yeah.
So, you know, it's just something to think about.
Yeah.
We will come to Lisa.
Hi, Anna.
Hi, how you doing?
Good, thank you. I actually will get to see you. I'm very fortunate. I live in the Netherlands, and I'm coming to the UK end of August.
Great. Did we already have a chat? Did you?
No, we have a chat in June. We have an online setup for June, and then hopefully, all things going well with the corona restrictions, I'll be able to come over.
Right.
So I find I've been to 2 physios. I find them very. I find the Netherlands even more behind than the UK. I find them quite, you know, the physios quite arrogant. They don't take any complimentary things into consideration here. So I think I know I have a lot of tension. I've also suffered from fibromyalgia for quite a few years. So I know that I have a lot of tension. So I guess my questions was, do you know of anybody in the Netherlands?
Not off the top of my head, no, but I can tap into my forum.
Yeah, I would be very grateful.
Netherlands.
I mean,
There's people called Pelvic Guru, and they have created a listing.
Okay.
But it's a listing of everybody that's gone, oh, I'd like to be on your listing. So what you're going to find there is numbers of people. And then you've got to then trawl through that a bit and go, do you treat the way that I want you to treat? So, but still, that's a good start point. So that's Pelvic Guru.
Okay, great. Thanks.
They're not really in the UK. In the UK, the best way to find a physio that's going to help you is the Mummy MOT network. Okay, so the Mummy MOT network. And in fact, that's probably worth a look in other European countries as well, because some people do travel over from other European countries to the UK. So yeah, that's where I'd start if you're looking for a physio that's going to be more progressive.
Yeah.
The Mummy MOT.
Yeah, because I mean, I find that the hypopressives has definitely helped me. Funny thing is, I went into it because I have a prolapse, but what I'm actually finding is my body has, I think somebody else said it, but it's a similar thing with me. My body's so twisted, especially my right side. I have, you know, I noticed that my whole shoulder is it's just pulled over. So I'm actually finding a lot of release there through, because a lot of my tension through my right side. I'm also, as long as I know my body is, you know, my pelvis is already twisted. So that's probably also not helping. And it's internally on the right side, it's just rock hard internally.
Okay. So that sounds like we need to unravel that torsion. So the body distorts and changes shape in response to tension because it's really functional. That's the body doing a really great job of keeping you alive and keeping you moving around. You know, where there is a tension or restriction in the body accommodates by changing shape slightly so that you can still function. So obviously, the more of a twist or a change in shape in the body, then, you know, the more discomfort and pain. But it's all sortable, it's all correctable. There's a point, once you have a surgical intervention, I've said this before, once you've had a surgical intervention, that ability is then reduced because the body is inherently changed. But up until that point, the body is changeable, the body will respond. So, you know, it sounds like you perhaps need to get on and find somebody like an external myofascial release therapist or an osteopath or somebody to start, because if per se, for example, the tension is started in a shoulder injury, you know, and then the body will accommodate that by just changing shape slightly. So that's then your pelvic torsion. So then the internal pelvis is really tight. So that's your prolapse. So your way out of that might be to sort the shoulder out, allow the body to work in a more balanced way. This is going to allow the internal pelvis to switch off, and so the organs to be in a happier place. So usually the best way forward is your lovely, well supervised, probably quite expensive Pilates or yoga class, and your highly qualified body worker who can see you fortnightly for 6 months.
Yeah. Yeah.
So,
I mean, I already go to see an osteopath every two months. I've been doing that for years, which is, he's actually, I have quite a lot of, he's definitely good, but it might even be worth trying to see somebody who is, what you just said, a bit more aimed towards the pelvis, the women's sort of problems, issues.
One of the issues that we have as well, you know, I can't speak for the chiropractors and the osteopaths, but in physiotherapy training, we come out of university knowing nothing about the pelvic floor. We learn every muscle in the body down to the little finger and not the pelvic floor, right? So there's this massive gap. Yeah, it doesn't exist. It doesn't exist in the textbooks, and where it does exist in the textbooks, it's a flat two-dimensional structure, which is not the case, right? It's a bowl shape. So undergraduates, people who've just come straight out, are just not going to know that much about the inner workings of the pelvis. So the only way you're going to get that is by somebody who has gone and done extra training in that. Normally, the motivation for that, this isn't everybody, but normally the motivation for that is when women become mothers themselves and go, oh, wow, this is a whole area of the body that I haven't studied. Hang on a minute. So you will find that that's quite a common pattern of, you'll have somebody that is a physio, osteo, chiropractor, whatever, experience doing their job, has a baby. So yes, the majority of the people that have got good qualifications in pelvic floor work are women. Just, you know, you will find the odd man, but it's broadly speaking women, because they get to a point where they've experienced that themselves and go, oh gosh, actually, this is really important. Why is nobody treating this? Oh, that's me then. Right. Okay. Off I go and do some courses. Yeah. So yeah, you get some really great fellas too. I'm not denying that, but the majority of the better qualified people you're going to find probably going to be mothers.
Okay. Thanks.
Yeah. I mean, that's exactly it. We see majority of the people that come on our training courses have found us because they've tried doing it through their own, whether they're a chiropractor, whether they're an osteopath, whether they're a physio, a yoga teacher, a Pilates trainer, and they haven't got where they need to be. So they're trying to find something else to help fix themselves. And I can say that because I did it myself. I went down that route, and I really just couldn't find anything until I found some hypopressives. So, and
you know, for me, it was a big change. You know, I didn't do women's health work until I had my kids, and I was like, oh, all of it. Oh, pelvic. Oh, this is really important.
Yeah, absolutely. Well, so glad you did. Thanks, Lisa. Right. Thanks. Come to Mandy.
Hi, I'm under Amanda.
Under Amanda. Hello.
Hi. Mine is more of a, I teach yoga and Pilates.
Sorry, I'm just struggling. I've got a bit of hearing loss, so just bear with me.
I've got to shout a bit.
Maybe just come a little closer. I think it's heavy.
Turn it up a bit. So I actually teach yoga and Pilates, and I'm one of the Hypopressives senior trainers as well. And one of the methods that I use, which works with your myofascial stuff, is, I'm not an instructor or anything, but it's a melt method for myofascial release. I found that really...
Yeah, they've got a really great rep. Yeah, I've met them at the British Fascia Symposium. So yeah, that's a great suggestion. If you're not able to access a myofascial release therapist near you, then yeah, the melt method, it's myofascial release that you can do yourself to the whole body, isn't it?
Yeah, it's really nice. She's got like a whole book you can buy, and it kind of gives you all the basics, which I found really helpful.
Yeah. If you've not got a therapist near you, that is certainly an option. Yeah.
Yeah.
Right.
So this is mainly and yoga tune-up as well. Same kind of.
Okay. I don't
myofascial.
Yoga tune-up.
Yeah.
I'll look them up. Great. Certainly the pandemic has really brought a lot of stuff online as well. It's actually one of the silver linings, isn't it, of a lot of people that were developing programs actually have moved a lot of stuff online, which really increases the accessibility. So for some stuff you really need to see somebody in person, but actually there's a lot that can be done with online programs.
I just kind of wanted to say if that's quite helpful for other people maybe to use, like Michelle, if she can't get hold of anyone overly regularly.
Yeah, it's good.
Cool.
Thanks. Brilliant.
Okay, let's come to Ella.
I need some help to do that.
Sorry, I suddenly moved off the screen and I couldn't find myself. Hi Anna, sorry, I joined a little bit late, so I'm really sorry if this was one of the first questions that was asked, but it's really useful everything you've been saying. So I've, like somebody earlier, definitely have noticed that I've got a lot of tension, and I've seen a myofascial specialist, and she said I'm twisted to the left very much and I need to sort of even myself up. The problem was she was such a journey to get to, so I didn't do it, and I didn't feel it was making that much of a difference. And I guess there's two things. I kind of have two questions. One is regularity. How often would you recommend actually doing something like that? Because it probably would make a difference. Do you know anyone in London as well? Is probably the other that you'd recommend. And then lastly, really silly question, but what is your view on Kegels? Is it that you shouldn't do them?
Yeah. Okay. So just to clarify, the person that you've been seeing for myofascial release, is that internal or external?
It was internal and external.
And you couldn't find that in London?
Well, to be honest, she was recommended to me by somebody else with a prolapse, because I've got quite a severe prolapse. And then when I looked in London, I kind of almost wanted to go for someone that had come from a recommendation.
Got you.
So it's more that I didn't know where to look with someone who is specific to prolapse.
Okay, cool. So there's somebody fantastic in Hatfield, and there is a few people in London.
I'm South London, if that helps at all. Southwest.
Over the next couple of weeks, I am doing a training program for like about a dozen physios, and I'm sure a couple of them are London. So what I was going to do, that's on the 14th of June, so quite soon. What I was going to do as soon as I've done that is list them on my website.
Brilliant.
So can I, rather than give you names now and not get the locations right, if you just check on my website after the 14th of June, I'm going to list everyone that's done training with me, and I'm sure a couple of them are London and South East.
Okay.
So what was the second question?
Is how often would you recommend myofascial release?
Well, it depends on the practitioner. So some practitioners go like, a week or two and then leave things for a while. Some practitioners will say, let's go fortnightly. Some practitioners will go monthly. So I think really that depends on the practitioner and the stage. For me, when I'm seeing patients, I like to see people about every 2 or 3 weeks until we've made a certain amount of progress. And then I'll say, right now, let's leave it for a month to 6 weeks to allow that change to integrate, and then go again, probably a month to 6 weeks after that. And then probably move to something like call me when you need me. So so that's my way, and everybody works in a slightly different way. So I think as long as they're getting onto the structures that need releasing, I would just follow your practitioner's lead. Yeah.
And then the last question was Kegels, and you said no.
Kegels. I actually just don't think they're very good for prolapse at all. I think they are next to useless, and for many women make things worse. So
I think it makes me worse. I try and do it 3 times a day, and I notice straight after it definitely feels. I do my hypopressives first thing in the morning, and straight after that it feels great, and then I do a Kegels at lunchtime, and it just suddenly seems to.
Kegels is repeated squeezing of a muscle. This is not a functional way of using a muscle, and its only basis, the only reason why you would suggest somebody would repeatedly squeeze their vagina is if you believe that the vagina is holding everything else up from below, which it's not. It is not. Okay. So the anatomical basis for Kegels is wrong. All right, so some women might have a reduced contraction, yeah? So you might have seen a women's health physio, she's had an examination, she's gone, right, you've got a reduced contraction. So in the old anatomical model, the one that is now out of date, if there is a reduced contraction, that's got to be due to weakness.
Okay.
Right? So she sees a reduced contraction and she goes, that's weakness, you need to do your Kegels, right? In the other anatomical model, if there is a reduced contraction of a muscle, it's because that muscle is stuck down, stiff, adhesed or tight. So you release that stuckness, that tension, that adhesion and that tightness, and that muscle will then go back to its full range of motion. All right, so what we want from our pelvic floor is a dynamic, elastic and reflexive pelvic floor. Yeah, if it can't contract, okay, in my opinion, the odds are, particularly if you've got prolapse, the odds are that that is because that tissue is stuck and adhesed down.
Okay.
There's no other muscle in the body where we would say, okay, so she's got a big 2-inch cut from that, you know, an episiotomy, a tear, an injury, a stiffness or a stuckness, and the answer would be repeatedly squeeze it. We would never say that for another body part. We would never.
Yeah.
You've got a muscle tear, repeatedly squeeze that. We wouldn't do that because that's wrong. Yeah.
Yeah.
But I actually don't ask anyone to do Kegels. I don't think Kegels are the right course of action for prolapse. In my recent research thingy that's nearly out, it says in it quite clearly, everybody that came to see me, I asked them to stop doing Kegels. We focused on release work, got to the end of treatment, and not only was their prolapse better, but their pelvic floor strength had improved by 2 grades, it's quite a lot, by not doing Kegels and by focusing on release work instead.
Just made my weekend.
Great.
Do I have to do them again?
No, if you have a prolapse, I think they are the wrong thing to do. If you have a prolapse, I would not recommend that you do Kegels. I think they have the potential to make things worse.
Thank you.
I don't think they really help women with prolapse at all. The evidence, even the trials, big clinical trials that say that are all about doing your Kegels, that are all biased in favour of Kegels, say they help a few women a tiny little bit for a very short time. They don't improve prolapse grade. They don't reduce onward referral for surgery. That is what the clinical trials that are in favour of pelvic floor muscle training says. So the evidence that we have that says do your pelvic floor muscle exercises says it's next to useless. Right? And that's without considering the fact that it's based on an anatomical model, which is wrong. It's not actually weakness, because the vagina doesn't actually hold everything up from below. Yeah?
Great, thank you.
I love
I
it.
feel quite strongly about it.
Right, Claire.
Hello. You might have already just have answered this question actually, but I'm in France, and when I had my pelvic re-education, which you get after you've had a child over here, it was, but really they only did Kegels and where they kind of have the machine, you know, so you get the TENS machine in a way, and I think the problem is I live in probably quite a country place, so there's not really much going on here. The only other thing I've had recommended was surgery, which obviously I really didn't want. When I had my child, I had obviously forceps and episiotomy, and and I had no problems before that. And then obviously afterwards, I had the prolapse. And my thought was, at the start, I was obviously thinking, oh, it must have been because of all of this, you know, with the forceps and everything, they've damaged the muscles and there's a weakness there. And obviously now, yeah. Is it the weakness that causes the tension, or is it just the tension's already there?
This is the crux of the argument, right? We know pelvic floor damage, pelvic floor injury, and pelvic floor dysfunction or problem is linked. That is the truth. Pelvic floor injury and pelvic floor symptoms are linked. Pelvic floor injury in the form of episiotomy and forceps massively increases your chances of having pelvic floor issues later. The debate is, does that injury cause tissue laxity and weakness? Or does that injury cause scar tissue, which tightens, stiffens, and tenses things? So the injury is the truth. The debate is, does that injury cause weakness and laxity within the pelvis? Or does that injury, if it's a scar, we know for a fact that scar tissue stiffens and tightens tissue. So if we've got an injury in the pelvic floor, we can choose to believe that that injury to the pelvic floor made that woman's pelvic floor weak, or we can accept that that's what actually has happened, is that she's now got scar tissue in there, and scar tissue we know tightens, stiffens, and adheses.
Yeah, that sounds
the only gap is the recognition that birth scars matter. That's the only knowledge gap there. We know that pelvic floor injury and pelvic floor dysfunction are linked. We know that scar tissue tightens and stiffens up tissue. But women who have pelvic floor injury are then told that they are weak.
Yeah, that's all I got told, basically. Yeah, keep going and doing your Kegels and, you know.
That is still the mainstream.
Yeah, okay.
Yeah, this is the revolution. You guys right here are the revolution. It's not happening before us. Didn't happen a year ago, 5 years ago, 10 years ago. This right here is how the change gets made, by saying that.
Yeah, okay. Yeah, that's good. And obviously hypopressives have helped amazingly. And is there anything else?
Internal manual therapy too, though.
Okay, okay.
You're going to need internal manual therapy.
Okay, and that's...
You'd be able to find that in France.
Okay, and just...
travel.
Right, okay. That's just look up internal manual therapy and see...
Yeah, I would be looking up myofascial release, women's pelvic health myofascial release.
Okay.
Something
All
you
right.
should find somebody in France who will do internal myofascial release for you.
Okay, brilliant. Thank you.
Claire, I know a women's health physio in France.
Okay,
so, and
good.
She does hypopressives as well. She does the training courses out in France. So
okay,
might be a good one.
It can be hard finding people. One thing that people do is join a local support group, like an online support group, a French prolapse support group, and ask on there, does anyone know anyone that does internal myofascial release work? You should find that in France.
Yeah.
Okay, brilliant. Thank you.
You need to do that. If you've had an episiotomy and forceps, you definitely have scar tissue this long in the right-hand side of your pelvis. So your prolapse is almost certainly on the right-hand side. Your pelvic dysfunction is almost certainly on the right-hand side, because if you've had an episiotomy and forceps, you've got a scar this long into the right-hand side of your pelvis. That is pulling its way through your body. Yeah.
Yeah.
You've got
yes.
Here. Yeah. And what that's going to do is, there's your prolapse.
Right. Yes. It is the right. I mean, yeah. That's absolutely right. Yeah. Thank you. It's like a breath of fresh air.
On my website, there's a webinar for sale. It's not much, it's like 20 quid, something like that. And in there are some self-massage techniques. But what I say in that as well is that it's really important that you also get assessed, that you're also under the care of somebody. So what I would suggest you do is go onto a French prolapse support group, look for somebody that does internal myofascial release, go travel and see them. That's just how it is. I'm sorry, we don't have people in every city.
No, that's fine.
Just go and travel and see them. go a few times and ask them to teach you some self-massage techniques, or show them the ones that are on my webinar and say, do you feel like this is safe and right for me? You know, so what I've put on that webinar is really just like a basic set of techniques, but really the best thing to do is go see someone who can look at you and go, yeah, that's good, that's right for you.
Okay, that's brilliant. Thank
but
you.
For sure, episiotomies have a lot to answer for, and you will need internal myofascial release of that episiotomy scar.
Yeah, brilliant.
And that's going to be difficult to find.
Yes, I'll do it. I'll travel. It's all right. It's a day out.
It is.
Yeah, thank you.
Claire, I've put in the chat, I've put the name of the woman before I forget, that might be in touch with. I don't have her contact details, but she's trained with us, so she definitely will know somebody.
About tapping into networks, isn't it? Because we don't have enough people. You know, this is stuff. You know, this is happening, but we don't have people everywhere. So, is a tear as bad as an episiotomy? The bottom line is that so Lorna Smith's just put that in the chat. A grade 1, no. A grade 2, no. A grade 3, yes. Right? So a grade 2 tear is not as bad as an episiotomy. I tore but wasn't stitched. That's probably okay. That's probably okay. The stitching is sometimes, if you had a tear that wasn't stitched, that's probably not too bad. So you might need to do some internal work on that as well. It really, really depends on what happened with that. A grade 3 tear is usually more significant tension-wise than an episiotomy, and a grade 3 tear will affect both sides because of the way 2 C-sections. Yeah, so Romy, 2 C-sections, you have got a better chance of finding someone who can help you with that C-section scar. Finding someone who's trained in C-section scar massage is not that difficult compared to finding someone that can help you with an episiotomy or a tear scar. So just find somebody in the Netherlands before you come and see me. Find a body worker who can do C-section scar massage, okay? Or you can start doing it yourself. There's actually, like, if just YouTubing C-section scar massage, you'll find something. So start mobilizing that C-section scar. But grade 3 tear, you're going to see tension on both sides. You are going to need myofascial release internally on both sides.
So let's just come to Sarah Jane.
Sarah Jane.
We'll have to make that our last question today, unfortunately, because keep it short.
Hello there.
Hi.
I'm actually in Spain, but I do come to in normal times, I do come to the UK. I mean, I'm quite happy to go and see Nikki. I've looked up where Fareham is. I'm also happy to go to Leeds. I just wanted to ask you, I mean, in actual fact, this ridiculous squeezy app that the NHS has online, I mean, that's all to do with Kegels. Why do they promote that so much? Because
they still believe in the old model. The NHS still believes in the old model. I am doing my best to change that. I've written nice guidelines, I've written to the government, I've published research, I'm doing my best. And I don't think that is going to change for 10 years, even if we all go on about it every single day.
Takes a long time. It's a pity. And I mean, somebody like Nikki doing the classes every day, when you first start out, you think, oh, well, I'll just do it for a month or so. But actually, it's actually very good to have somebody making you do hypopressives daily, because you think, oh, I'll have a look and see what she's doing today. She changes it daily. And I mean, I have quite a bit of pelvic pain. I've got a grade 2 cystocele and a grade 1 rectocele. And I find before I go out for a walk, if I do half an hour of hypopressives, it seems to lift it all up, and I don't have any pain when I go out for a walk. If I go out for a walk without having done the hypopressives, I have to come back and put my legs up the wall for 15 minutes. So they do work, definitely.
Just so that you understand this.
Yeah.
The pain and the prolapse.
Yes.
It's not that the prolapse falls down and sits on that painful area and causes the pain.
Right.
that the prolapse comes down and sits there on that painful area. That's
okay,
not
so
what is
so
actually happening is that that painful area is tight tissue, and when it's tighter, it's more painful and it pulls things down more.
right, okay,
So releasing that tight and painful area is going to allow the organ to lift. It's not that the pain comes from the organ sat on that area. It's that that area being tight pulls
okay,
the organ. So if you focus on releasing and letting go of that tightness through any which way you can, movement, massage, mindfulness, releasing the tension and tightness in that painful area,
yes,
what's going to allow that organ to move into a better position, because it's that tight, painful area which is pulling.
okay, it's very interesting. Thank you very much. We'll have to...
The organs don't sit on the muscles. This is another massive myth. That dragging sensation is because the organ is being dragged by the tightness. The heaviness sensation is not the organ sat on the pelvic floor. They're like that far apart from each other. That heaviness is actually the muscle tension, just like the sensation that you have when your shoulder is really stiff. It is a heaviness sensation. That's the sensation going on down below. The heaviness sensation is muscle tightness.
Muscle tightness, okay. And there's nothing like that Kegel 8 machine, that which is like a TENS machine.
No, thanks, no.
No, nothing like that. Okay. And I mean, before they used to recommend weights, but that's not a good idea either, is it?
Terrible idea.
And, no, okay, my darling.
Is based on the concept that women are inherently weak and that we let go of our own organs. It's nonsense.
Right. Okay. Thank you very much.
We have an area of tightness and tension, and that pulls things.
Okay. Thank you. Thank you very much.
No worries.
Thank you very much for joining us. And
okay.
I'm sure everybody's going to be in touch with you now, unfortunately.
I can't fit anyone in though. I can't take any new clients.
I know that. It's fine.
What we need to do is go to our local providers and go, I need this, I want this. This is the evidence for the approach. This is the science behind the approach. And it's all on my website. You can share it all.
Yeah, brilliant. Fantastic.
All right.
Thank you so much for joining us and taking your time out to do this. It's been
No
amazing. Problem. Take care. Thank you.
Have a nice day, everybody. Bye.
Okay, so guys, that was fairly amazing, wasn't it? What a great Q&A. Hopefully you've all understand a little bit more what I've been rattling on about in the last few weeks, few months, few years. And it's so great to have someone who's actually done some research, got a couple of research papers behind her now, because that's always been our sticking point with hypopressives, is not having done the research. It was Richard, my other half's, intention to do some research, but COVID kind of put the dampeners on that for a while, and now he's just too busy. It's just one of those things. But has anybody got anything just for this final sort of 5 or 10 minutes that they wanted to talk about or ask me while I'm here? Oh, you're very welcome, Ella. Yes, you do. You do need to find someone. I've put, if you look in the chat, everyone, there's some useful people. So obviously Anna said Claire Sparrow, if you want to go down the Pilates route. I still think with something like hysterectomy, there's lots of work that can be done with hypopressives as well. For Tabitha in the States, there's Herman and Wallace, but also you know, anybody, that's all accessible. It doesn't matter if you're not in the States, you can still access all of this stuff as well. So it's worth having a look at these people that we've put in there. The MELT method, I know someone local to me actually that introduced me to the MELT method quite a few years ago. And she was actually a hypopressive trainer as well. So it's interesting how it all kind of interlinks. Rebecca Davies is someone that's worth looking up. She's actually on our website under in the trainers directory. She's a women's health osteopath, and even if she's not local to you and you can't travel to her, I can't remember where she is, but she's worth looking up as well. She might know someone. She trained with Renzo Molinari. He has his own training, osteopathic training school, is very, very knowledgeable. So then maybe he may have a list or a directory like we do of trainers or osteopaths that have that specialism as well. So do have a look at that. And then Annie Vitris Malongo. She is a hypopressive trainer as well as a really, really knowledgeable women's health physio and a really lovely person. And she, even if she is a long way from you, I don't know where you are or where she is particularly, it's worth getting in contact with her and just asking her, because she will know of someone that will be able to help you. So yeah, I think that was all the people we had there. Make sure you make a note of those names if anything's applicable to you. There's so much available online now. You know, you may just stumble across some bit of, you know, gold. If you find something, please add it into the group. As you can see, there's lots of people here. We need to share all this knowledge. We need to get it out there. We need to be saying to people, we want someone that can do this, especially with hypopressives, you know, and point them our direction for courses. Okay, so has anybody got a question? We're all right. Good. Yeah, there really is been some amazing nuggets of gold, I agree. And it's been great to see you all this morning. It's lovely to see some faces, and go and have a great day armed with your knowledge about what you can do for yourself. Thank you guys, take care.